In the first video, we focused on the anatomy of the heart and also the cardiac cycle. In this video, we're going to talk about electrical activity in the heart, and we're also going to look at the coronary arteries themselves. Before we start that, I just want to remind you of the importance of understanding the cardiac cycle and how we get changes in ventricular volume as we move through the different parts of the cardiac cycle. In addition, you need to make sure that you understand the pressure gradients and how they determine the movement of blood from one part of the heart to another part, and also how those pressure gradients explain the opening and closing of the AV valves and the semilunar valves. Now, you know that the job of the heart is to serve as a pump and to push blood through both the pulmonary and the systemic circuit. And to most effectively do that, all of the thousands of individual myocardial cells have to work as if they were a single myocardial cell. This is referred to as a functional syncytium. And so that's how the ventricles are working as a functional syncytium. The reason that they're able to do that is because the action potentials that start in one area are very rapidly transmitted to all of the myocardial cells. And we've talked about the reason for this back when we discussed the nervous system and synaptic transmission. The thing that allows myocardial cells to do this is what are known as gap junctions. And when we look at the diagram below, we'll notice that there is an area where two myocardial cells come together. This is what's called the intercalated disc. It's that little zigzaggy line here. Well, we can't see the gap junctions until we actually open up the intercalated disc between two myocardial cells. And now you can see those gap junctions down there. Here you can see an enlargement of the gap junctions. What you can't see is the corresponding gap junctions on the underside of this myocardial cell, and they line up directly with the gap junctions here, as you can see in this diagram. In fact, there are way more gap junctions in an area than you see here. Rather than being fewer than 10, there are probably more than 30. And what this does is it causes a direct connection between the cytoplasm of one myocardial cell and the cytoplasm of another myocardial cell, and so we get direct transfer of action potential electrically from one cell to the next cell. And this is much, much, much faster than trying to use chemical synapse and release neurotransmitter. And so the action potential travels very quickly through all of the myocardial cells of the ventricle. Now, the heart has its own little internal nervous system, which is actually made up of nervous tissue. It's not muscle tissue, it's not connective tissue, it's not epithelial tissue. It is, in fact, nervous tissue. The two biggest parts are the nodes. And so we have an SA node, which is located up near the top of the right atrium, not very far from where the superior vena cava comes in. This is what's known as the heart's pacemaker, and it sets your resting rhythm. We have another node, which is the AV node, and we'll look at nodal cells in a little bit. From the AV node, we have a bundle of His, which moves down the septum between the right and left ventricle. And it very shortly divides into two branches. Those are known as right and left bundle branches. And then as those branches get down near the apex of the heart, they branch even more extensively and become what are known as Purkinje fibers. And they're very thick, which makes conduction of an action potential really, really fast. And this too helps to ensure that the heart works as a functional syncytium. All right. Now, you know that if we removed any nervous input to your heart but kept it alive, it would still continue to beat, because we've said that in class, and then some of you have studied that in biology classes that you've taken previous to this. Well, the question might be, how is it that that's going to occur? The term that's used to describe this property of the heart is automaticity. And so again, it can beat all on its own, even without any nerves coming to the heart. And so I want you to be sure that you're familiar with figure 1916 on page 753 in your textbook. This shows you a nodal cell, and so again, I just want to reiterate that this is nervous tissue, and we're going to get action potentials in this nervous tissue similar to action potentials that we've gotten in neurons, and so we've already talked about that. And you know that in order to get action potentials, we need to be able to change the permeability of membrane. You also know that the way that we change permeability of membrane is by using ion channels. And we use ion channels that are gated so that we can have them closed at some times, but then we can open them at other times. And so that's what you see here. Now you can see that we have voltage-gated sodium channels and voltage-gated potassium channels, just like we did in neurons, but now we've added one. Now we have a voltage-gated calcium channel as well. What you don't see here is we have sodium and potassium leak channels, just like we did in neurons, and we also have calcium pumps that aren't shown here. Here we see two action potentials that we might find in a nodal cell of the heart, and so these could be occurring in the SA node, and that's what will happen in healthy individuals whose heart is working the way that it's supposed to. And look at this and see if you can identify some of the differences between an action potential in a nodal cell and an action potential in a neuron. And you might notice that there doesn't really seem to be a resting membrane potential. The membrane potential goes down to -60, but it doesn't get down as low as -70. But then very quickly, the potential starts to drift upwards with kind of a shallow slope until it reaches threshold, which occurs at a higher level than it does in a neuron. The other thing that you might notice is the peak of the action potential isn't quite as high. And what we're going to do is we're going to go ahead and look at how all of this occurs. And so this shallow upward sloping part is what's known as the pacemaker potential. So sometimes we refer to the whole thing as the pacemaker potential, but it's really this shallow upward sloping part. And you can see that it's really opening of slow sodium channels that allows sodium to move into the cell, causing this shallow depolarization that you see here. So again, we open up the slow voltage-gated sodium channels, sodium moves in, and we depolarize the membrane up to -40 or threshold. At this point, what happens is we open up calcium channels. These are fast voltage-gated calcium channels, and so calcium is going to flow very rapidly into the inside of the cell, depolarizing it more quickly until we get to the peak of the action potential. And so again, those fast voltage-gated calcium channels open up. When we get to the peak of the action potential, the calcium channels will close, and then just as we're used to in neurons, potassium channels open up. And as those potassium channels open up, potassium is going to rush out of the cell, causing it to repolarize very quickly. And so again, voltage-gated potassium channels open, potassium leaves, and it pushes the membrane potential back down to -60. Again, when we hit -60, that's going to be the stimulus to open up the slow sodium channels. And for that reason, these were previously known as funny sodium channels. We tend not to use that terminology anymore, but that was what we used to say about them. It was the repolarization that opened them, and so they were funny. They weren't typical sodium channels. Then we just start all over again, and so you know this is going to continue. If you have a resting heart rate of 60 beats per minute, this is going to happen 60 times in a minute. If you have a resting heart rate of 70 beats per minute, it will happen 70 times in a minute. What would be the effect on heart rate of a drug which blocks some of those slow voltage-gated sodium channels? Well, as you can imagine, sodium wouldn't enter the cell quite as fast. And so the slope of the pacemaker potential would be more shallow. It would take a little bit longer for us to reach threshold, and as a result, we'd have a slower heart rate. This slower heart rate would help to lower blood pressure a little bit. Conversely, we can actually increase the speed at which sodium enters the cell, and that's going to give us a pacemaker potential which is similar to what you see for the green line. It's going to be steeper, we'll reach threshold faster, and we'll have more heartbeats in a minute. That's what happens when we put epinephrine or norepinephrine onto the heart, or we activate the sympathetic nervous system. And so there you can see that shallower slope. Okay? If you look here, you'll notice that the y-axis of this thing is in millivolts. And so you might think that, oh, maybe this is an action potential too. And you'd be right. That is what it is. It's an action potential that we would find in a myocardial cell. And so this is a third type of action potential that we're going to look at. And over to the right, you can see the ion channels that are located in the myocardial cell. And again, you see voltage-gated sodium channels, voltage-gated calcium channels, and voltage-gated potassium channels. But now it's the voltage-gated sodium channels which are fast, and the voltage-gated calcium channels are slow. You look at this and you also notice that it has a very low resting membrane potential, which is really close to the potassium equilibrium potential. And that is because the resting membrane is leakier to potassium, and so more potassium leaks out, driving the potential down lower. Well, when the Purkinje fibers pass the action potential to the myocardial cells, that's going to open up the fast voltage-gated sodium channels, and sodium is going to rush in very quickly, and so the slope of the line is almost vertical. And so we depolarize very, very rapidly. You can see that we get to a potential of approximately plus 15 millivolts here. At that point, the voltage-gated sodium channels close and voltage-gated potassium channels open up. Well, again, potassium is going to leave, and that's going to start the repolarization of this thing. Well, after a very brief period of time, we open up the slow voltage-gated calcium channels. And so calcium comes in, and that slows down the repolarization of the myocardial cell. It's still repolarizing, but it's repolarizing much more slowly. These slow voltage-gated calcium channels very quickly will close, decreasing the calcium permeability and letting repolarization continue more quickly. And so finally we get back to about negative 90. There's a very important reason for this. By slowing down the repolarization of these myocardial cells, what we actually do is we increase the duration of the absolute refractory period. And if you think about it, it will make sense to you that we would do this. You have to remember that after contraction of the heart, we have to fill the ventricle up with blood. We need to ensure that there's enough time for this to occur. And having a longer absolute refractory period will give more time for the ventricles to fill with blood. Again, as we've already said, the SA node is really the pacemaker of the heart. And so in healthy hearts, it's the SA node that determines the rhythm or the resting heart rate. Now, other tissues can take over that function if there's something wrong with the SA node. And so the AV node or even other cells might take that over. And so we find that all of the nervous tissue in the heart is actually autorhythmic. But the SA node is the normal pacemaker. The SA node is going to pass the action potential across the myocardial cells of the atria and down to the AV node, but at the AV node it slows down. And the reason for this is because there are smaller diameter fibers, which means the action potential will travel more slowly, and there are fewer gap junctions between cells, nodal cells in the AV node, and so the action potential doesn't move quite as quickly from one AV nodal cell to another AV nodal cell. And again, this allows blood to move from the atria to the ventricles before the ventricles contract. And so we've got a couple of different ways that we try to help ensure that the ventricles fill up with blood before we contract and push blood out through the systemic and the pulmonary circuits. What we see here is what's known as an EKG, and most of you recognize this. An EKG gives us the electrical activity that's occurring in the heart as a whole. And so it includes action potentials in the nervous tissue of the heart's internal nervous system, and also the myocardial cells of the heart. And so that's why these things don't look like normal action potentials that we're used to. But you can see there are different parts to the EKG. And first we see this P wave that's indicated here in green. The P wave actually corresponds to depolarization of the atria. And so as they depolarize, we get this upward deflection here. The next thing that we see is, again, that little nodal delay before we get to what's called a QRS complex. And the QRS complex is the depolarization of the myocardium. And since there's a lot of myocardium, we get a fairly large deflection, and the QRS is very, very big. Well, the other thing that you know is once tissues depolarize, they have to repolarize. And then this last wave that you see, a T wave, is the repolarization of the ventricles. And then we're back to normal. And the EKG is a really, really, really important diagnostic tool that we can use to look at many, many, many different problems that can occur in the way that the heart is working. Here you can see an older gentleman is being run through what's called a stress test. And we can do stress tests in our lab as well. Electrodes are placed on his chest so that we can actually go ahead and get the EKG. And so you can see we can put electrodes on anywhere from 3 up to 12. Here's the normal EKG, and here's the EKG during a stress test in which a person is not getting enough oxygen to their heart. That's indicated by what's known here as ST segment depression. And so this is the area between the end of the QRS and the start of the T wave. And it's down below the baseline, and so this is a classic sign that an individual's heart is not getting enough oxygen. Here are some other abnormalities that can show up in EKGs. I'm not going to expect you to learn these. I just want you to understand that the EKG is a really, really important diagnostic test. Oftentimes when we do resting EKGs, everything looks great, but it's not until we stress the heart, and the best way to stress it is to do exercise, that EKG abnormalities start to show up. And so that's what I really want you to take away from this. And so you can look at these and see some of the differences. Tachycardia is just an abnormally high heart rate. And so not surprisingly, you can see that there. And then we can get things like premature heartbeats. Here you can see ventricular fibrillation. This is very bad. This means that the action potential is not being passed very effectively to the myocardial cells, and they're all working individually. It's no longer working as a functional syncytium, and so it's not effectively pumping blood out to the rest of the body. And if this isn't fixed very quickly, the person's going to die. The most effective way of fixing this is to use an AED or the automatic defibrillators that we see all around the place now. All right, so we're going to quickly look at coronary circulation or blood flow. The heart cannot get its blood supply. It can't get its oxygen and nutrients from the blood that fills the ventricles. It has its own arteries that feed it. And if you look over here very carefully, you can see that those arteries actually arise off of the base of the aorta. That's what we have. And blood is supplied to the heart by two major coronary arteries. Here's the right coronary artery coming off this way. And here's the left coronary artery coming off the other way. And we have branches here. Here you can see the marginal branch of the right coronary artery. And then there's another branch that goes around to the back, which is known as the posterior interventricular. You know, inter means between, and so it goes between the two ventricles. And then the left coronary artery, we can see branches into the circumflex, which also wraps around to the back, and then the anterior interventricular. And this You can see those on the back as well. They continue around that way. These figures don't show you the extent to which the coronary arteries really branch. Here's what is known as a coronary cast. And so what's been done is the coronary arteries have been filled with a latex-like material, and then the myocardium has been chemically dissolved away so that you can get a better idea of how extensive the blood supply to the heart is. And you might remember from our discussion of energy and metabolism, the heart is very, very, very aerobic, and so it needs a constant and a very good supply of blood and oxygen to serve as the final electron acceptor. Now, you also know that sometimes coronary arteries get plugged up, and they get plugged up through a process known as atherosclerosis. The first thing that has to happen before atherosclerosis can occur is damage to the endothelium of these arteries. And once damage occurs, then fat can get in here underneath the endothelium and start to build up. And you can see here's a nice healthy coronary artery with no damage to the endothelium. Here you can see damage, and here you can see that the artery is becoming progressively more and more narrowed as atherosclerosis continues. The things that can cause damage to the endothelium include high blood pressure, smoking, high blood sugar. And so having high blood sugar even just for a short period of time can cause some damage here. Having it continually over many years can allow this process to really become pretty bad. And then oxidized LDL cholesterol. You might remember that LDL stands for low density lipoproteins. And these are things that actually contribute to the process of atherosclerosis. And so you don't want to have lots of LDLs floating around in your bloodstream. Here you can see atherosclerosis in a coronary artery. And so there it is. And you might wonder how it is that we can tell when somebody has the buildup of that plaque there. And again, the first thing that we do is we do a stress test. And if we find ST segment depression or other indicators that the person's heart is not getting enough oxygen, then what we're going to do is we're going to go in there and we're going to look at it. And what we do is we actually feed a catheter up through the aorta. It's coming through the aorta and around to the base of the aorta. And then what we do while we're x-raying the heart is we actually release some dye that moves through the coronary arteries. Here you can see again that dye in the right coronary artery before it branches. Right there you can see some dark shadowing. That shows us that there's plaque there due to atherosclerosis. And then the surgeon can look at that and determine how extensive it is and whether or not anything needs to be done to treat it. Here you can see that what we do is we make an incision down here, sometimes it's a little lower on the thigh, and we feed that catheter all the way up through the aorta and again around to where those coronary arteries come off of the aorta. And again, that lets us get a good look at these things. Then what we can do is we can go ahead and feed a catheter up through there that has a balloon on the end of it. This is what's called balloon angioplasty. And what we're doing is we're pushing the plaque in the arteries back against the wall, trying to open up the lumen a little bit more to allow blood flow to get through here. And this always hasn't worked that well. It works better in people who are very compliant in terms of they don't use tobacco anymore. If they had used tobacco, they cut back on fat in their diet, and they also become more active. If they don't do that, then not surprisingly, this will close right up again. And so one of the things that they've tried to use, not very successfully, to help keep this open after they do balloon angioplasty is what's known as a stent. And so here you can see the stent on that balloon, and as the balloon is inflated, the stent is opened up. And this is just a little mesh wire cage. The goal is to try and help hold the lumen open. But again, success with stents has not been that good. It hasn't been great. And so the other thing that gets done is what's known as coronary artery bypass grafts, or CABG. And here what we've done is we've taken artery from someplace else. Sometimes they've tried to use pig artery, sometimes they've used artery from cadaver, but we always have problems with rejection. And so what works best is if we take a vessel from the person the CABG is being done is. And sometimes we get a piece of vein from the upper leg, sometimes we get artery from the abdomen. But again, this is what's known as coronary artery bypass graft, and sometimes people get 1, 2, I've even heard of people who've gotten 5 coronary artery bypass grafts, or what's known as a CABG. Here you can see sometimes we tie in other places. We don't always tie in at the aorta, but we'll tie in other places as we do this. And so here you can see they've used the saphenous vein to do the CABG in this particular case. And so that brings us to the end of this video, and we'll have another video on the cardiovascular system talking more about the vascular portion of it.